Okay. Good evening, good afternoon, and good morning, everyone. And I welcome you all from Asia, from Europe and America. And I welcome all the attendees from all over the world. And today we are here again for our second session of our webinar. And today's theme is New Horizons for EUS. And I want to thank the Pentex Medical, Singapore, Asia Pacific, India, and Pakistan for arranging this. And we have today in our agenda distinguished faculty from India and from Singapore. And today's session will be chaired by Dr. Christopher Khor. And there will be two speakers today. One is Dr. Malay Sharma from India. He will be speaking on EUS guided vascular therapies. And I remember him seeing his video in one of the highest forum at ASGE World Cup, where he presented EUS guided coiling of the hepatic artery two-stage method. And it will be honor really to have him in our webinar. And the second one will be Dr. Chin Yunka from Singapore. He will be speaking on overview of endohepatology. So the first I'll introduce our session chair, Dr. Chris. He is the senior consultant and in Department of Hepatology and Gastroenterology in Singapore General Hospital, also associate professor in Duke and US. He is the executive committee in the GI-TEP Asia Pacific Task Force and also the vice president of the EUS Asia Pacific Task Force. And he has a very huge number of citations and publications, and it's an honor again, Dr. Chris, to have you here to chairing the session. And in the first part of the session, we will have the presentation from Dr. Malay Sharma, and I hand over to Dr. Chris for the introduction of Dr. Malay, our distinguished faculty. Hand over to you, Dr. Chris.
Thank you, Adeel, for that very kind introduction. It's a huge pleasure to now be able to introduce our first speaker for this evening. Dr. Malay Sharma is a huge presence in interventional endoscopy and especially in interventional EUS. He is a pioneer in the area of especially vascular therapy in EUS as a one of the pioneers in EUS in India, and especially he has written a significant number of publications, and I especially remember his really groundbreaking book on EUS anatomy. So it's terrific to have him here tonight to talk to us to give us a very nice, and I'm sure it will be a very detailed introduction into vascular therapy in EUS, really, and that really qualifies as one of the new horizons in EUS. So Dr. Malay Sharma is from Meerut. He's from this is and he runs a terrific course every year, which is really gives a lot of insights into therapy endoscopy. So without further ado, may I call on Dr. Malay Sharma to present his talk to us. Go over to you, Malay.
So we start our lecture today on EUS guided vascular intervention. EUS guided vascular intervention is an uncharted territory. Stay back. But this has been chartered, and this is the procedures that we have done for varices, non-variceal bleed, vascular punctures, pericardial mesothelioma aneurysm, and thrombolysis in pulmonary venous system and pulmonary artery. What are the principles of chartering the vessels? Principle is very simple. You block the unblocked vessel which is bleeding. For example, these are the bleeding vessels. But the problem is you have to identify the source of bleed. On the left side, it is the satellite barracks. And this right side, this is duodenal barracks. And this is a place where the bleed is coming from outside paragastric varus into an ulcer in the stomach wall. And these are relatively simple gastric varices and the duodenal ulcer. But this does not look, last one doesn't look like a duodenal ulcer, it is in fact a rectal varix. So second principle of charting is unblock the blocked vessels. That is, if there is thrombosis of the portal vein, you unblock it. to cause thrombolysis. But where can we exactly go? What are the territories that can be traversed? This figure shows that you can traverse anything by EUS. Superior vena cava, inferior vena cava, left atrium, aorta, IVC, the aorta and its branches, and the gastroduodenal artery. And that is what we are going to see, what vessels we can charter. So first is EUS guided diagnostic issue. This case came, GI bleed, we were going to do ARCP, but when we saw blood coming out of a nape papilla, we hesitated, and then we proceeded to make a diagnosis of EUS guided diagnosis of pseudoaneurysm, hemosuccus pancreaticus, puncturing going into the pancreatic duct. Another example, dual of ulcer, duodenum, EUS done, dual of ulcer demonstrated, submucosal arteriole running from the muscularis propria. And then another example, a young girl, this is a bleeding vessel. We were not so sure that this is a dual of ulcer or a bleeding vessel, but then we applied over the scope clip after doing endoscopic ultrasound. So these are the examples where we are taking EUS assistance in doing diagnosing a bleed cause. Another example, 50-year-old man, pancreatitis, required blood for stabilization. And endoscopy showed this picture. Somebody thought this is an ulcer, and this is another side viewing endoscopy shows this is still an ulcer, but there is something in the middle of it. And then we did endoscopic ultrasound, found an aneurysm, and this aneurysm was seen on CT, pseudoaneurysm, and this pseudoaneurysm was subsequently obliterated by, because this was a pseudoaneurysm coming from the gastroduodenal artery, into which we placed coils by an endoscopic ultrasound guided needle, 1 coil, 2 coil, 3 coil, and then multiple coils were placed, and then the pseudoaneurysm became smaller, the flow became faster, and this is subsequently further injection was given of thrombin, and multimodality management was done to ultimately more thrombin, and this is how the aneurysm flow stopped. But EUS is not only assistance, as we have just seen EUS is puncturing. And we puncture the vessels, and the second indication is puncturing aorta. For example, you see a mass beyond aorta. How do we go into this? You go through the aorta. You push the needle out, you go into the node through the aorta, and that is the idea that you can do endoscopic ultrasound guided FNAC after puncturing through the aorta. The only thing is you should be careful that you should be going from the middle part of the aorta and not from underneath. The other diagnostic issue is if it is a case of portal vein thrombosis, whether this is malignancy or not, and you do a puncture in portal vein thrombosis to find out that this is a case of malignancy involving the portal vein and inoperable pancreatic carcinoma. But EUS moves puncture to intervention, and then we puncture the vessels, and which vessels can be involved, and how do you block them? Glue, coil, thrombin, or gel foam. Anyway, so we will go coil, microcoil. Larger coils are used by 0.035 wire, and smaller coils are deployed by the floppy part of the respective guide wires. The interesting part in every gastroenterologist practice is portal hypertension, where we see fundal varices, and this is a fundal varix which is seen very clearly on endoscopic ultrasound, submucosal fundal varix. And then what we do is You place a coil in it, and in earlier parts of our practice, when we were placing coil, we were not exactly measuring the size of the coil. And in this case, the first coil was very small. It kept on moving within the vessel, and ideally should have been slightly bigger than the size of the varus. But subsequently, a larger coil was placed, and more coil. And after placing the larger coil, then last part, 3 coils were placed. And once 3 coils have been placed within the varix, then you place in some glue at the final part. And in this case, you see the stomach coil glue causing acoustic shadow. A bleeding ulcer in stomach. EUS done, submucosal tumor. No, this is varix. What do? You inject it. Inflowing perforator, outflowing perforator, and this is how it looks after injecting. You inject gastric varix, esophageal varix, but sometimes the bleed can be from extragastric varix. As happened in this case, there was an ulcer from outside the stomach wall, and this was ulcerating after extrusion of glue into the stomach, and paragastric glue injection was given, which resulted in obliteration of the tract from which the blood was coming out, and ultimately the bleed stopped. So hidden varices are one example. You look on endoscopy, you see nothing. You see some prominent, but when you do endoscopic ultrasound, these are duodenal varix, antral varix, gastric varices, and these duodenal varix can be banded by application of band from below upwards. You first go to the lowermost down varix because the flow is from below upward, and then you inject. Similarly, another case of duodenal varix, you detect it, and once you detect it, they are ectopic varices and they require obliteration. A case of interest, because you see rectal varices, the flow is from above downwards, and when they go inflow zone, they flow down, and then ultimately in the anal canal, they flow out. So this is the principle of rectal varices hemodynamic evaluation. So what do? This case, what bleeds in the rectum? Okay, these are, in a case of portal hypertension, never think this is duodenal ulcer. It is ectopic duodenal rectal varix and banded, but the patient had rebleeding from a point above the rectal varix, and it is again looks like another duodenal ulcer, but this was again banded, and this was all the time rectal varices, and the principle is band the highest rectal varices. Esophageal lowest varices, duodenal lower varices, rectum highest varix first. So these are the principles. The next is non-variceal upper GI bleeding. When we manage non-variceal upper GI bleed, example, this is a case, periampullary tumor, bleeding tumor. We could not stop by injection of adrenaline, endoscopic ultrasound done. We saw this is the bleeding area. We injected alcohol into the bleeding vessel, around the bleeding vessel into the periampullary tumor, could not stop the bleed, decided to do endoscopic ultrasound identification of gastroduodenal artery. Into the gastroduodenal artery, then microcoils were placed, and these microcoils first the blood. We identified this gastroduodenal artery first by pushing in flow, and then the coil, this is the coil which is moving inside the gastroduodenal artery, and it resulted in stoppage of the bleed within from the tumor. And after later on, when the patient was stabilized, the coils were recovered from the dissected specimen. Pseudoaneurysm, though I have already discussed, but I will briefly come back. Case of complex bile duct injury, find aneurysm, and you identify this is an aneurysm by endoscopic ultrasound, and this is endoscopic ultrasound, you do thrombin injection, and once you inject thrombin into this, the aneurysm disappears. But in the meantime, so this is pseudoaneurysm. in complex, and this is another example of a case of gastroduodenal artery aneurysm diagnosed on ultrasound, into which we could inject again first thrombin, and you can see the thrombin entering into the lumen, slowing down the flow of the blood. Always shake. Thrombin is given in 5 steps, shake it, and then the picture changes. The blood flow disappears. It starts thrombosing. And once it starts thrombosing, it works in boluses, and we can give boluses. And these are the EUS guided treatment, thin wall or thick wall, small size or large size, and you can select from one option or the other option. Coming to unblocking the blocked vessel. Till now we have talked about how to block the vessel, but the next interesting part is how do you unblock the blocked vessel. Okay, this is called EUS guided thrombolysis of the portal venous system. This is a case who came, there were thrombosis of splenic vein and the confluence of superior mesenteric vein. Then we did a CT, and on CT we found that the thrombus was very much there within the portal vein. Endoscopic ultrasound was done. Endoscopic ultrasound showed that the thrombus was there within the splenic vein near the hilum. Only a small part of the splenic vein was patent. So what to do? We wanted to offer thrombolysis in this case, but where to offer thrombolysis? We decided to select the superior mesenteric vein because superior mesenteric vein is the main vessel which you need to save when it comes for management of thrombolysis. The needle was injected into superior mesenteric vein from the second part of duodenum through the pancreas, and a guide wire was advanced into the patent part of superior mesenteric vein. The needle was removed. After removal of the needle, a tapered tip cannula was advanced over the guide wire, and then this is the picture that shows tapered tip cannula was advanced over the guide wire. And this is the cannula going through the portal vein, advancing. This is the C-arm image showing the advancement of the cannula over the guide wire into the branch of the tributary of the portal venous system. And then the guide wire was removed. And then this is an image which shows nasomesenteric study of the superior mesenteric venogram. The scope was removed. Then the same cannula was removed and cut. It was fitted with a syringe pump. And then continuous streptokinase infusion was started. It was given for 3 to 4 days. The patient's symptoms immediately subsided. It became better. And the infusion was continued in this case. We have done 8 cases so far. The infusions have been continued for 3 to 10 days. And this is the picture once the thrombolysis has been achieved. There is still a thrombus in the splenic vein, but the portal vein has recanalized and the mesenteric vein has also recanalized. So we are talking on one hand of thrombolysis. We are talking on one hand of stopping bleed. On the other hand, we are talking of opening up bleed. The opening up of block system is much less common. But there is another example that we can do pulmonary artery thrombolysis. This is a case of thrombus in the pulmonary artery. This is the pulmonary artery thrombus. Generally goes more often to the right pulmonary artery. Systemic anticoagulation in this case was contraindicated in view of recent history of hemorrhagic stroke. And this is a picture which shows the right pulmonary artery. So initially, we injected thrombus into the thrombolytic agent within the thrombus. This is the thrombolytic agent within the thrombus. But when we decided that this thrombolytic agent was not going out, we injected a little bit of thrombolytic agent outside the thrombus also. This was 1080 place that we were injecting, and pulmonary arteries are easily punctured. And this is what happened after 48 hours when we repeated an endoscopic ultrasound. The patient's symptoms immediately disappeared. And this is the picture that we see after 48 hours. The last part is EUS guided creation of the portal systemic shunts. The principles are simple. We have to kill two birds with one stone. We have to puncture one needle. The needle has to puncture the portal vein. And in this case, this is wrongly marked as hepatic vein. The structure is in fact inferior vena cava. So we go from the inferior vena cava. This has not been yet done. These slides are not mine. This has not been done. But you go through the inferior vena cava into the portal vein. This is the needle going through the inferior vena cava first. And we can see rotate it, and then afterwards go into the portal vein. And then into the portal vein, we pass in a guide wire. Once we pass in a guide wire, then we can pass in a stent, dilator over the guide wire, pass in a stent over the guide wire. And over that stent, then we can subsequently proceed to deploy a shunt. This is the distal end opening within the portal vein, and then the proximal end is supposed to open within the inferior vena cava, and this is the principle of EUS guided portal systemic shunt placement. There are emerging indications. The emerging indications are, you can see in this case, you see liver, and within the liver you see a lot of blood. And in this case, you can also see that the blood is tracking back. What happened? What went wrong? In this case, a EUS guided hepaticogastrostomy was done. And then we were trying to readjust the position of hepatogastrostomy stent. The stent slipped out all the way. And it slipped out all the way. It sheared the left branch of portal vein. And once it sheared the left branch of portal vein, at this time, patient was bleeding massively. We were able to do endoscopic ultrasound guided obliteration, the left branch of portal vein with cyanoacrylate glue, and the patient survived. So these are the emerging indications. So I will say in summary, endoscopic ultrasound can assist us. We have diagnostic issues. The diagnostic issues when I practice, I look at every bleed with suspicion. At our center, we do not allow the residents to do biopsy in a case of portal hypertension in almost any case. We want them to look first by endoscopic ultrasound what is lying beneath the mucosa. This morning only rectal varix was identified by endoscopic ultrasound, and then the rectal varix was banded from above downwards. Second issue is EUS guided vessel puncture. What vessel can you puncture? Okay, the arteries are favorable to you. You can puncture through the arteries more favorably, but not the atherosclerotic artery. Do not puncture the atherosclerotic artery because there will be more chance of bleeding. Do not puncture from the side of the artery. Try to go into the middle. Sometimes you can go through and through. What about venous puncture? I have a tape. All these anesthetists who put in central lines. They put in a central line, and when they are putting in a central line, what are they doing? They are going blindly into the internal jugular vein. When they are going blindly and when they are removing, nothing happens. My take is you puncture the vessels with impunity. Do not worry about it. EUS guided management of varices. Yes, we have to stop variceal bleeding. There are many ways: coil, glue, ectopic varices, band, EUS guided, EUS assistance, identification, and then proceeding. Non-variceal upper GI bleeding. Every bleed, we look at suspicion. Unidentified cause. We have a long list. Dula ulcer, Hemosuccus pancreaticus, hemophilia, whatever are the causes, we always try and do endoscopic ultrasound, and we are almost always able to do something. EUS has an impact in medical practice. In at least 30% of cases, everyday management makes a difference. EUS guided management of pseudoaneurysm. I would say pseudoaneurysm are important causes of bleed. We have done till now about 14 cases of pseudoaneurysm. We have learned some hard lessons. We have learned that one of the hard lessons learned has been that we put in glue, but the flow was fast and the glue went into the peripheral part out of the pseudoaneurysm. So we realized that put in a coil first and then the glue will stay. More likely, we thought it is a small pseudoaneurysm. Just put in glue, buy a coil, but it went out. Every year, we get 4 patients where there is thrombosis within the portal venous system, acute thrombosis by dilated part of the portal venous system, and we save them. They come in bad state, not infarcted. Thrombolysis of pulmonary artery, yes, it is a thing we should be doing more often. We have got portable machine also, where we can take the patient, take the EUS machine into the ICU, and we can order for pulmonary artery thrombolysis. Looks a very simple thing to me, and you should have the courage. The EUS guided creation of portosystemic shunt is a thing which is evolving, and it will take time, and let us see where we go from here. Thank you very much, and it was a pleasure. I thank you all, and on 26th and 27th of this month, I welcome you all to join a virtual conference from our center, which will be where we will be discussing mainly about endoscopic ultrasound basics and some live cases. Thank you.
Thank you very much, Malay. Terrific. And please send us details of your forthcoming meeting. We have a few questions already from doctors who are attending. The first one is from Dr. Quang Tran, and I presume he's communicating with us from Vietnam. And the question is, can you tell us the risk of bleeding after transaortic puncture? What is the risk of bleeding after puncture of the aorta that you showed us, and what needle do you use for that?
Needle, 22 gauge needle, go through aorta, do not go from the side, do not go to atheroscleral aorta. Aorta almost always collapses, no problem. No problem.
Right, and the reason why there is not much bleeding is because the muscular wall is very thick in the aorta, is that right? Elastic, and also it's important, as you're saying, to go right through the middle so that you don't lacerate. Is that correct?
Yes.
Okay, thank you very much. Thank you very much. Second question was also from Dr. Tran. What's the advantage of thrombolysis with EUS guided route versus the percutaneous route that the pulmonologists or the cardiologists and the IR people do?
This is an interesting question. Intervention radiology is not easily available everywhere, and we are far more in number. Number two, portal vein is not easy to enter. You cannot enter portal vein. I think we are the best, most suited people to enter portal vein, and more than portal vein, superior mesenteric vein, you cannot enter, and you cannot thrombolyze. What route you will select? Intervention radiologist, how will they go there? They cannot manage. This is beyond them.
Yeah, that's an important point, that only EUS can access the portal vein easily, isn't that right?
Sorry, I didn't get the question.
Yeah, no, I think I was saying that you make the important point that only endoscopic ultrasound gets easy access to the portal vein.
Yes, very easy. And right now we have done more cases. We are realizing that you just give streptokinase and come out even if you can't do anything, because streptokinase has a short life, and 7 minutes it thrombolizes and the pain goes within half an hour. The patient wakes up and says, "Thank you very much, doctor. My pain is gone." It is like giving streptokinase in myocardial infarction. No pain. So this streptokinase in myocardial infarction, pain is gone. Same way streptokinase in superior mesenteric vein related infarction of bowel, the pain is gone. Thank you.
Thank you very much. What about the next question? Which gauge and type of needles do you use for vascular puncture? And I would presume that for coil deployment, you're using 19 and 22 gauge needles. Always 19 gauge? You don't use the smaller coils?
Microcoil 22 gauge, microcoil 22 gauge, thrombin 22 gauge, glue 19 gauge.
So when do you use the microcoils versus the normal size coils?
I use in a gastroduodenal artery related bleed for puncturing small arteries.
So I have a follow-up question to that, and that is compared to the interventional radiologists who are able to do to super selectively cannulate a small bleeding vessel versus EUS, where you just identify the GDA and then you have to embolize that. What's the risk in EUS guided?
No, I will give it gladly to intervention radiologists. I am doing it just because the patient cannot be sent to them. Transfer take 3 hours.
I see. Okay, so in that situation, IR is still preferable.
It is the backup.
Okay, thank you very much. There's another question from Dr. Faisal Wasim from Aga Khan University Hospital, and in 2 questions. So I'll ask you the first one. Where in the algorithm of management of non-variceal GI bleeding will EUS fit in? So non-variceal upper GI bleeding, where would you make use of EUS guided therapy?
Always in diagnosis. First in diagnosis, non-variceal diagnosis. Dula ulcer.
To find the vessel, huh?
Define the vessel. Hemococcus pancreaticus, hemobilia. Then, in the case of pseudocyst, there will be aneurysm bleeding into the pseudocyst after bleeding left gastric artery or splenic artery aneurysm bleeding into pseudocyst after surgery.
Okay, thank you. Second question from Dr. Wasim. Can glue or histoacryl be used for EUS guided variceal bleeding management? And presumably, I think you've answered that question because you use coils with glue as well?
Yes.
I presume maybe Dr. Wasim is asking, do you just use glue alone in EUS guided variceal therapy?
So we do EUS guided variceal therapy for gastric varices, duodenal varices, rectal varices we put in glue, duodenal varices assistance diagnosing, rectal varices sometimes we put in coil, duodenal varices I have not put in coils, but whether assistance is needed, whether direct therapy is needed, that is what we have to decide.
Okay, so you do sometimes use glue without coil?
Yeah, we sometimes do without coil.
Okay, and how do you decide whether to use glue alone?
And massively bleeding, cannot see anything, cannot retroflex, I will use EUS.
Okay.
Cannot see anything, EUS will see the varix.
There's a related question about using from Dr. Heba in the UK about using coil and thrombin for gastric varices instead of using coil and glue.
See, we are just evolving. We still don't know which one is better. So I really don't know how to answer this question. But to each is his own.
Can I ask you about thrombin? How viscous is it, and do you do you have trouble pushing it through the needle?
So thrombin is 22 gauge needle, very good. Never trouble. It doesn't coagulate. Thrombin, 5 bolus is 1 bolus, weight, 2 bolus, weight, 3 bolus, weight, 3 bolus. The only thing is thrombin retracts and the aneurysm comes back. So be careful. Do it next day.
Okay, thank you very much. Okay, I think we've come to the end of our questions for Dr. Malay Sharma. Thank you all for submitting, and I'll hand you back to Dr. Adeel for Dr. Chin's introduction.
Thank you.
Thank you, Dr. Sharma and Dr. Chris. Amazing presentation. I would like to presentation again and again. So we come on to the second part of the session, and we have our distinguished guest from Dr. Chin Yunka. He's from Singapore. He's consultant in Department Gastroenterology and Hepatology, also assistant professor in Duke and US Medical School. He did his graduation in medical school from UK. Did his training in medicine and gastroenterology from Singapore. Then he has his advanced endoscopy EUS fellowship from University of Santiago under Professor Julio Gracia. And he's also one of my favorites, and whenever I see his presentation, the resolution of the ultrasound is amazing. So, and one of the unique thing I saw Dr. Chin doing is left hand intubation, especially the Pentax 3870. That is very unique from that center, and I wish after the presentation he can comment on that as well. So, and he was awarded as a WEO Star Award as well in 2019. So we welcome Dr. Chen for today's presentation. Your talk on overview of endohepatology. Okay, over to you, Dr. Chen.
Hi, thank you, Adeel, for the kind introduction. Thank you very much for the organizing committee for giving me this opportunity to give a talk on this overview on endohepatology. I do not have any disclosure. Okay, what is endohepatology? What immediately springs to mind are procedures related to pictures shown in this slide. However, with further literature search, it is more than what meets the eyes. It is actually not about treatment of portal hypertension like varicose ligation or gastric varix injection. But before we go into any details, I would like to draw your attention to the pancreaticobiliary specialty. It has endoscopic control for imaging, tissue acquisitions, and interventions, whereas this is not the case for hepatology specialty. Hepatologists usually turn to a radiologist for liver imaging and interventional radiologists for liver biopsy and management of portal hypertension. It would be most ideal if the assessment and treatment of the liver disease and portal hypertension could be performed and assimilated by this primary GI specialist. So while the current role of endoscopy in hepatology practice is limited to assessment and treatment of varices, there are emerging applications of EUS to patients with liver disease. Endohepatology is the term coined by Dr. Kenneth Chang from University of California, Irvine. It basically tried to assimilate the EUS procedures with hepatology. It encompasses the procedure shown in the diagram, like for instance, EUS guided liver biopsy, coil glue injection in gastric varices, portal pressure gradient measurement, ascites detection, paracentesis, and also shunt creation. In my opinion, for endohepatology, it will be incomplete without discussing EUS liver anatomy. So, liver segmentation usually described according to this current classifications, which divides the liver into 8 functionally independent segments. Bhatia and colleagues, they actually describe the landmark structure that are relevant for endosonographer for assessment of liver anatomy. Now we start discussion on the left lobe of the liver. As the scope passes through the GE junction and is then rotated counterclockwise, the left lobe of the liver is identified. And the left hepatic vein can be seen as a long vascular channel with a thin hyperechoic wall, which divides segment 2 and 3. Then a slight clockwise rotation will review the portal vein branches. When you follow the respective portal vein branches in the left lateral segment by rotating clockwise and slightly pushing the EUS scope forward, the umbilical portion of the left portal vein is visualized. And then a thick hyperechoic band expanding from the umbilical portion of the portal vein to the anterior superior surface of the liver is the ligamentum teres. Okay. And then on further slight clockwise rotation, the ligamentum venosum is seen as a thick hyperechoic band running from the umbilical portion of the portal vein to the inferior vena cava. So then on further clockwise rotation and slight withdrawal of the scope, the medial hepatic vein can be seen entering into the inferior vena cava. And 3 liver segments can be visualized in this plane: the caudate loop between the transducer and the ligamentum venosum, and the middle hepatic vein separates segment 4 and from segment 8. Then EUS examination of the right lobe of the liver is not as straightforward as its majority of the segments are further away from stomach or duodenum and they have lesser anatomical landmark. So as the scope passes through the parallels, it is pushed into the apex of the bulb and forming a J-shaped configuration. The scope tip is directed superiorly and the probe now faces backward. The portal confluence immediately comes into view, and counterclockwise rotation and following the portal vein will direct you to the scanning plane into the liver hilum. And then slight counterclockwise rotation again will bring in the cystic duct and gallbladder into view. Then the main portal vein is then traced to its bifurcation. And you can see that the right portal vein branches into anterior right portal vein, which drains from segment 8 and 5 anteriorly. And from here, the reverse maneuver will bring the right portal vein before its bifurcation. And then at this point, a slight counterclockwise rotation of the scope will bring the posterior right portal vein into view, which it received drainage from both segments 6 and 7 posteriorly. Okay. EUS examination of the liver should be part of a routine upper abdominal EUS study, and with careful technique and detailed EUS evaluation of the liver is possible. A thorough understanding of the liver anatomy by linear EUS will form the backbone of transhepatic EUS guided intervention. Now let's look at this EUS evaluation of liver surface. Conventional transabdominal ultrasound routinely utilize this low frequency to assess the liver parenchyma, shape, size, and the hepatic vessel. And the sound wave need to travel across this thick abdominal wall before reaching the liver surface. This may be a problem if the patient has high BMI. In contrast, EUS uses higher frequency to assess the liver surface, and there is no artifact from abdominal wall or bowel gas. This provides higher quality images compared to the conventional abdominal ultrasound. Okay, during the initial assessment of the liver surface, few information can be obtained from here. Okay, take a note at this. These are the EUS images of the left liver lobe from 2 different patients. As you can appreciate, the image on the liver image on the left has smooth edge, whereas the one on the right is irregular and more nodular. And there's a less displacement of the liver parenchyma when the EUS probe is being pressed down onto the liver surface. So this information gives a general sense of the status of the liver condition. So now look at the assessment of the focal liver lesion from EUS. Okay, Fujilau and colleagues, they studied EUS images from 200 patients and they developed a validated EUS scoring system by looking at certain EUS feature. And this features scoring system has a positive predictive value of about 88%. Okay, with this system, the presence or absence of certain criteria increases the accuracy to differentiate between malignant, benign, or indeterminate focal liver lesion. So based on their criteria, benign solid focal liver lesion are distinctly hyperechoic, as you can see here, and then they have this sharp geographical edge. Whereas for the malignant lesion, they have these 2 components. You can see the central hyperechoic, and they distort the surrounding structure, and there's the posterior acoustic enhancement, and some of them are more hypoechoic, and they are usually larger than 1 centimeter. So incorporating all these 7 features into the scoring system, then they're able to distinguish between benign from malignant hepatic masses with a relatively good AUC of about 0.8. Okay. So there are adjunctive methods to further evaluate focal liver lesion. Transient elastography is one of them. Okay. We know that different pathological processes, including inflammation, fibrosis, and cancer, will induce changes in the tissue. So malignant tissue tends to be harder, and whereas the inflammatory one tends to be softer. So elastography is very much similar to palpation technique in physical examination. We palpate during physical examination to ascertain the firmness of a lump or nodule. Similar principle apply in elastography. Slight compression with the EUS transducer over the target lesion. And also, while doing that, you must bear in mind that there's a vascular pulsation and respiratory movement will also provide vibration that may also contribute to the compression needed. So after that is done, then you select the region of interest that you want to do the assessment on. Usually that area include the target lesion plus the surrounding tissue. And subsequently, the elastography pattern will be superimposed on the conventional B mode. So this is the pictorial demonstration of elastography. At rest, the harder tissue is within the softer organ. After compression, the tissue will be hard. The harder tissue within this lesion will be less distorted than the surrounding tissue. Okay, so elasticity is depicted using a color map with a scale of red, green, and blue. red being the softest and blue being the hardest. And this can be further quantified using a hue histogram, whereby the x-axis represent the elasticity from 0 to 255, whereas the y-axis represent the number of pixels of each color within that region of interest. And mean value is calculated to tell you, give you a global sense of global hardness of this of the lesions. So this is an example of a hue histogram of a solid lesion, with the graph mainly distributed in the blue region. This lesion is suggestive of a malignant process. And another quantitative analysis is using a strain ratio, whereby they're comparing the ratio between area B and area A, whereby area A is the region of interest over the target lesion, whereas area B is the reference area, usually a normal area, for instance, a gut wall layer. So this is an example of an inflammatory lymph node, whereby they have a low strain ratio. So it's suggestive of a benign condition. So this is a EUS of a focal liver lesion. Based on the previously described EUS criteria, it has few malignant features. It shows two components, and then it is more than 1 centimeter, and posterior acoustic enhancement, and it's a little bit hypoechoic. So the elastography actually show a predominantly blue pad color over the lesion, and this suggestive of malignant process. Another adjunctive method to evaluate focal liver lesion is contrast enhanced EUS. Okay, we know that our ultrasound contrast agents are microbubble of approximately 2 to 5 micrometer in diameter, and they oscillate to the sound pressure and have a variable asymmetrical diameter of between 2 and 10 micrometer. There are various kinds of ultrasound contrast agent, but the one that's more familiar to us is the Sonoview. It consists of sulfur hexafluoride gas with a phospholipid shell, and it can be oscillated and broken down by lower acoustic power, providing a better visualization of tissue. When this ultrasound contrast agent receives certain range of acoustic power, they produce a second harmonic component. And that's when your EUS processor picked up this second harmonic component, which result in selective visualization of the microbubble within the vessel. And this allowed the microvessel and parenchymal perfusion to be visualized. Given the dual supply of the liver from portal vein and hepatic artery, 3 vascular phases can be observed. The arterial phase can last up to 45 seconds. The portal venous case can go up to about 2 minutes, and the late phase persists until clearance of the ultrasound contrast agent from the circulation. Sometimes it can go beyond 3 minutes. So there are several advantages of this contrast enhanced EUS over CT scan or MRI, because first of all, it's performed in real time, and then it is renal not excreted by the kidney, so it is used safe in an individual with renal insufficiency, and it stays within the vascular space without extravasation into the interstitial fluid. Therefore, it allows a prolonged enhancement of the vascular system and the evaluation in different vascular phases, as what we previously described. And it has a much higher resolution compared to other imaging modality. And this is an excellent safety profile, and is tolerable and make repeated follow-up examination easy. So differentiation between different types of focal liver lesion can also be studied through vascular enhancement pattern. So we know that HCC, they have arterial hyperenhancement with subsequent slow washout in the late phase. And then metastatic liver lesion, they have arterial hyperenhancement with a rim-like enhancement and subsequent rapid washout. And for hemangioma, there's a peripheral nodular hyperenhancement with centropetal progressive fill-in, and focal nodular hyperplasia. They usually has an unenhanced central scar. Okay, this is the contrast study for the same lesion from previous elastography. You can take the note of the enhancement pattern. There's a hyper enhancement coming in, arterial hyperenhancement at about 30 seconds, and with a rapid washout. This is consistent with what we previously described as a metastatic liver lesion. So the previously described techniques are complementary to histological diagnosis. They do not negate the needs for fine needle aspiration or biopsy. Now let's shift gear to discuss about EUS guided liver biopsy. EUS guided fine needle aspiration have been reported to biopsy focal liver lesion A with high precision, but its role in benign condition was a bit controversial until recent development of fine needle biopsy needle with evidence suggesting that this EUS guided liver biopsy also gives good diagnosis. This has gained some traction in recent years. Of course, it has some advantage because it allowed bilobar sampling and also concomitant endoscopic procedure like varicose screening, and can perform as day surgery. And of course, it can ensure patient comfort as well. Of course, they will pose some risk to certain patient population, especially the risk of sedation. So there are increasing evidence of EUS guided liver biopsy. This is one of the recent meta-analysis on this technique. The author looked at 9 studies with 437 patients. Majority of the indication are for benign condition, and the histological diagnosis was close to 94% with relatively good safety profile. And this result seems to be very promising. And this is an example of a EUS guided liver biopsy in a benign condition using a 19-gauge fine needle biopsy needle. It yielded a 4 centimeter length of core liver tissue in a single pass. So this slide shows basically the histological comparison of liver specimen from different biopsy technique. And this is the 19-gauge fine needle biopsy needle specimen. And it has more than 30 complete portal tract, whereas the percutaneous has smaller amount of tissue, and transject liver biopsy almost always has suboptimal yield with fragmented liver specimen. Okay, so we talked a little bit about EUS guided portal vein intervention. Okay, portal pressure gradient is derived by subtracting the hepatic venous pressure from the portal venous pressure. This pressure ideally should be obtained through direct venous puncture. Currently, the portal vein pressure is not routinely measured. It is indirectly estimated by the wedge hepatic venous pressure, which approximates the portal venous pressure in cirrhotic liver. Therefore, only the hepatic vein pressure is a true direct measurement, and the gradient is termed hepatic venous pressure gradient. So the journey of this portal pressure gradient measurement started when Dr. Ken Chang's teams did animal study on porcine model back in 2015. They compared the EUS guided portal pressure gradient measurement with conventional interventional radiologist HVPG approach. So they measured the EUS manometer and the IR balloon pressure concurrently in the porcine model. From the study, the EUS identification, access, and manometry was successful in all targeted vessels. There were excellent correlation between the EUS and IR method in all pressure range, and there was no adverse event reported. But they concluded that the technique of EUS portal pressure gradient measurement using a 25-gauge needle and manometer was feasible and demonstrated excellent correlation with the standard transjugular method throughout the pressure range. From then, they move on to the study into patients. So the equipment that was required are the compact manometer, a non-compressible connecting tube, and a 25-gauge FNA needle. The equipments are assembled into a single unit before used for this portal pressure gradient measurement. Okay. As previously described, a good understanding of the liver anatomy is important to identify the target vessel. The hepatic vein is identified and then serve as a target for portal pressure gradient measurement. Subsequently, the umbilical portion of the portal vein is the other target. So the difference in measurement between these two sites will give the reading for portal pressure gradient. So this video demonstrates how portal pressure gradient measurement is done. You first identify the hepatic vein, puncture it with a 25-gauge needle, and then you place the manometer in the mid-axillary line, and followed by flushing with small amount of heparin, and then you take the reading of the manometer reading once the reading stabilizes. And then you repeat the similar steps in the portal vein, and the difference in the measurement from both sides will be your portal pressure gradient. So in this case, the portal pressure gradient is 14, which is elevated. So then the same group did a retrospective analysis on their portal pressure gradient study in 28 patients. They reported 100% technical success with no adverse event. And they concluded that portal pressure gradient has excellent correlation with the clinical parameter of portal hypertension, including presence of this varices, portal hypertensive gastropathy, and thrombocytopenia. But the group also acknowledged that there is no standard criterion correlation with the IR because it is not a head-to-head comparison with the HVPG measurement. So now let's move on to talk about this EUS guided portal vein sampling. This is mainly done for assessing the circulating tumor cell. Okay, the rationale is that tumor cells are shaped into the vasculature before there's clinical evidence of this metastasis. So this CTC from the primary tumor are filtered during their transit through the hepatic portal circulation, resulting in fewer cells entering into systemic circulation. Therefore, this explains why the peripherally collected blood specimen for CTC is poor or suboptimal. So it is important to collect the blood specimen from the portal system for GI malignancy that drain primarily through the portal venous system to increase the yield. So the technique is very much similar to portal pressure gradient measurement. Standard FNA needle is good enough. Of course, they prefer larger gauge needle because it allowed adequate blood flow to minimize time within the blood vessel and hence reduce clotting. And then transhepatic puncture is recommended because of the benefit of the liver parenchyma to tamponade out of the needle tract. And try to use a smaller syringe instead of one large syringe like 210 cc versus 20 cc because you want to let the amount of time for the blood spent in the syringe lesser so they prevent clotting. And also careful withdrawal of the needle is important because after you obtain the blood, the needle is withdrawn into the sheath under direct EUS visualization. The intrahepatic needle tract should be observed under this color Doppler assessment for any persistent flow. So if you see there's still persistent flow, perhaps you might want to slow down the withdrawal until the blood bleeding is stopped before you pull out the needle. Okay, so this part has been covered by Dr. Malay Sharma in great detail. I think I will just skip this part. But one thing to note that this EUS guided portal systemic shunt creation has only been, the current evidence that's available is only in animal models. So I think there's still long-term data required with refinement of techniques and devices before this could be implemented in patients. Ascites, EUS in assisting in ascites detection and paracentesis. So we know that ascites can be due to portal hypertension, cardiogenic cause, nephrogenic cause, or malignancy-related ascites. So this paracentesis can be done with standard FNA needle. Of course, larger gauge is more preferred. It is mainly done for diagnostic purpose. However, there was case report for therapeutic paracentesis. But given the cost, procedure duration, necessity of frequent interventions, this EUS guided therapeutic paracentesis should only be attempted when percutaneous approach fail or technically not feasible. And EUS RFA has gained traction and attention in recent years. With the invention of this new RFA needle come in 19 gauge, they expand its indications. There are case reports of EUS guided RFA in HCC. Adeel and colleague reported a EUS guided RFA of a segment 3 HCC that was not accessible from percutaneous route. And so they first identified the lesion, they puncture it, and then start apply the ablation. So when you can notice that there's echogenic bubbles seen at the ablation zone, preferably to be done from distal to proximal part. And you can see that the needle is withdrawn and change axis, very much like how we do the fanning maneuver in FNA, and repuncture the lesion again to ensure the entire lesion is ablated. And this HCC actually shrunk inside after the RFA treatment. So current standard of care is endoscopy used mainly for viral screening and treatment. There are emerging and potential role for EUS in management of liver disease. Among the emerging EUS procedure, perhaps the more tangible or low-lying fruit that may be the EUS guided liver assessment and biopsy. However, many other possibilities will become reality as well. I think consolidating the surveillance endoscopy with a complete EUS evaluation into a single comprehensive procedure would optimize patient care, or rather would be the way to go for patients with liver disease in the future. Okay, that's the end of my presentation. Thank you.
Thank you, Dr. Chin. Great and excellent and very elaborative and extensive presentation. And I have a couple of questions. First question is from Dr. Abdul Qadir from Karachi. Besides SonoView, is there any other contrast agents available?
There are Sonozoid, but Sonozoid is more, at least in our unit, in our hospital, the Sonozoid are more preferred by the radiologists. But for us, gastroenterologists, we usually use SonoView.
So we have a question from Wenja Giljaka. So can you comment higher frequency of complications on EUS guided liver biopsy versus ultrasound guided 1 to 2% versus 0.25%? So can we minimize it by using hemostatic gel plug through the needle or other type of intervention if possible?
All right. From my understanding, how the radiologists did the biopsy is that they have a sheath in situ where they put the sheath there and then they punch the needle down, and then once they got the biopsy, they put the gel form or something like that through the sheath. But for EUS guided liver biopsy, we don't have that. The moment we pull out our the FNA needle, then the track is lost, and we need to find back the same track. So how can it be circumvented? Is by the video that I showed earlier on. When you withdraw the needle after your tissue acquisition, you slowly move your needle out, and then by under careful Doppler examination, if there's persistent flow, slow down the withdrawal. Usually the blood will stop on its own. And if still persists, you might have to use an elevator to pinch the parenchyma a little bit to prevent, to sort of like providing a tampona effect to prevent the further bleeding. I mean, slow down the bleed, so to say.
One more point, Dr. Professor Kenneth Chang from US, he mentioned, withdraw in a zigzag manner, not in a straight. So that is also useful to prevent bleeding.
Yes. Yes.
So I remember he mentioned once in the presentation. So we have a question from Shazib Anwar. How safe is EUS liver biopsy in cirrhotic patients, bleeding point of view? Maybe he's also asking bleeding profile, coagulation profile, how safe we can proceed.
So it's like all other patients. I mean, this cirrhotic patient, if they have a low platelet and a high PT or INR, so those has to be corrected before we proceed with any EUS liver biopsy. Apart from that, I don't think there's any increased risk for this group of patient.
Okay. What do you think should be the safety profile for coagulation parameters like platelets and INR? Yeah.
Okay. Any INR less than 1.5 or platelet of less than more than 50,000, I think it should be safe enough.
So, do you believe that the elastography will replace biopsy? This is a question from Marshall Binato.
Okay, so I would say elastography is a adjunctive or complementary technique to assessment of any liver or any lesion. It just provides additional information, but I wouldn't say that tissue is still the issue, and then we still need the histological diagnosis. I mean, it will not replace the biopsy. It's very unlikely. Yeah.
So the next question I'll also to you, and I think Dr. Sharma, I would like to comment on that as well. It's from Asma Asghar. So she said that seems like future optics in the hands of endohepatologist. So any comments?
Yeah, let me speak first. There is a lot of speech. We have published article EUS of hepatic vein and distribute, and EUS of variations of hepatic vein, EUS of portal vein and its branches, EUS of liver segment. Yes, EUS will be in hepatology in a long way. It will come and it will be easy to put in stand directly from IVC into the portal vein, it will be very easy. Stents will be very easy. You will be doing segmental analysis, segmental biopsy, chordate lobe biopsy, segment 2 and 3 biopsy, EUS guided radiofrequency ablation. So there will be a lot of future. And endohepatology does not end in the liver alone. EUS in portal hypertension, you will be evaluating varices, you will be eradicating varices, you will be ensuring varices are eradicated, and you will be seeing the varices remain eradicated. They do not come back as satellite varices to trouble you again, to bleed again, and to because as many as 10% of gastric varices rebleed. And remember, when they rebleed in a bad manner. They die. 10% to 30% is the highest number, is not a low number. Gastric varices rebleed. So in a case of portal hypertension, you will be doing a lot of EUS, ensuring varices, ectopic varices go, disappear. You will be ensuring the disappearance of ectopic varices, and you will be monitoring for follow-up that they remain disappeared.
Okay.
Yeah.
Dr. Chen, right? The Dr.
Sorry?
Chris?
Yeah.
Yes.
Anything to add? Yeah.
No, I think that's terrific. You know, very, very, very clear to me.
So in future, is there a possibility as cardiac stents, they are drug eluted, or in future we can use special stents to prevent thrombosis or more stent patency? Is there a possibility for that? Like for tips?
I'm not sure about that, but I think the first, before we have to go on to tips, we have to create a stent which is long enough to bridge both veins. So far, I think we don't have any ideal or suitable stents available yet. Until then, I think there's still much work needed to be done in this area.
So Leonardo is asking about differences between two needles during liver biopsy, the Frenzen needle and Proco needles. The complication, any difference?
So if you have to consider liver biopsy, I think you should go for the newer biopsy needle because of the design of the way that the tip of needle designed for tissue acquisition. I think if you look back into the paper closely, the Proco needle did not use so well compared to the newer biopsy needle. If you look at the individual the analysis, I think if you have to choose, you will go for the newer needle.
Okay. So Taran is asking, the RFA catheter, is it the same one we use for pancreatic cancer for SCC as well? Is it the same catheter?
Yes, this is the relatively new needle from the Korean company. Initially, they came up with 18 gauge, but over time they managed to miniaturize it a little bit to 19 gauge now.
Okay. Okay, Dr. Chris, any questions you wanted to ask or anything?
I think just a comment that about the needle type. I think it's really the Khor needles that have really shown the greatest progress. So the sharp Khor and the acquire needle, which really exceed the number of complete portal tracks that are required. As compared to the larger 18 gauge percutaneous needles in these studies. So I think the main issue I think for EUS versus percutaneous is number one, cost. The EUS procedure and the cost of the needle really is very high compared to percutaneous. But it may turn out to be safer because these patients don't need to stay with us for very long. And it may well be that the risk of adverse events is actually lower. but we need larger, studies to show this. Malay, are you doing, liver biopsy for diffuse disease in your center?
Yeah, we are doing liver biopsy at our center.
And is more EUS compared to percutaneous?
No, we are comfortable with both. The only thing is, probably I would say, when I do liver biopsy, I only see the tract. When the needle comes back, I monitor the tract for 2 minutes. If there is any backflow, then I put the pressure of the transducer onto the tract. That gives me a monitoring advantage. So that's all. It's probably safer. If my own relative, someone else, I would say EUS guided biopsy is probably safer.
There's been some concerns that the needle one of the three-prong needle design may actually result in higher risk of vascular injury. Have you seen that at all?
Yeah, that is possible. If there are multiple prongs, they can cause more vessel injury because you don't know where they are going.
Yes, these are just anecdotal reports, so we have to wait, I guess, for more data to come out.
Yeah, I can say that liver is an organ which has more vessels. So you have to be very precise. And if you are doing, there is a corded process. Corded process is the window for taking biopsy from right lobe of the liver. So most of the time, you have to go through the corded process into the right lobe of liver if you want to do liver biopsy, or you have to take corded lobe biopsy or left lobe, whichever you prefer. I don't know if there is any contraindication to taking biopsy from corded lobe, or it is not representative, but 3 biopsies we commonly take. Quite often we take corded lobe because it is easiest, and or left lobe. But if we have to take right lobe biopsy, then the problem is that you have to adjust an angle where IVC and portal vein, in between you have the corded process, move the knob up, go through corded lobe, through the corded process, which is the window to the right lobe of liver, and from there take the biopsy.
Yeah. I mean, the left lobe is usually more accessible, and if there's no need to go for the right lobe, I think the left lobe is good enough. I think.
Good enough. I agree.
Yeah.
The right lobe biopsy, there is a reason. I have a reason for a right lobe biopsy. There are sometimes metastatic lesions. Yeah. When there are metastatic lesions, then I am going into the right lobe biopsy to do EUS guided FNAC of very small right lobe.
Yeah, I agree. Okay.
There is a question from Renzo Pinto that what's the Dr. Chin, your liver biopsy technique? How many passes you perform? Sedation could alter the outcome. EUS guided portal venous greater pressure measurement as well. So how?
Okay, for the liver biopsy, I will just go for single pass.
Okay.
Single pass, yeah. 19 gauge needle single pass. That's all, yeah.
And for EUS guided portal vein measurements, you prefer sedation or MAC or anesthesia?
Well, I think if you were to do it, I think it's best to do it under anesthesia support.
Okay, under monitored anesthesia. Okay. Okay, there is a question from Dr. Kim V. Lim. In the event of emergent portosystemic shunt required in refractory variceal bleeding after band ligation applied in the prior OGD, EUS guided portosystemic shunt creation may be contraindicated. Then due to limitation in the presence of previous band applied. Is it correct, Dr. Sharma?
Yeah. See, I would say explain my take on bleeding. when is it refractory? Okay, few things. All hepatomas bleeding are refractory. They can be refractory for many other reasons, but hepatomas or fresh, newly emerging portal hypertension, acute portal vein thrombosis, these patients have higher portal venous pressure and they tend to rupture. What do I do? These patients commonly come to us when they come to us with bleeding and bleeding from the banded varixes, and that is the trick. Now, what is the trick? I personally employ glue injection below the varix, or if I cannot go below the bleeding varix, I go above the varix. And my trick is inject glue into a bleeding ulcer, bleeding ulcer, high pressure below the varix, above the varix, and if the glue comes out through the band, if the glue comes out through the ulcer, then the job is most of the times done. So far as shunt is concerned, our hospital does not have the facility to offer portosystemic shunts. So we have to live by these harsh standards, and we are almost always, we almost never lose any patient because of GI bleed in cases of portal hypertension. We glue esophageal varices also. Esophageal varices, esophageal ulcer varices, ulcerated band varices, whatever, then we start gluing them. There is, in my opinion, Shanks-Taken tube today is a waste basket. Fine, you cannot stop it, but if you cannot stop by endoscopy means, then Shanks-Taken tube is buying time. You will lose more patient than you will save. Okay. Probably they will die because of other reason, asphyxia. But we are proactive, very active. Stop the bleed, glue, whatever is, stop the bleed, stop. That is the answer.
Okay, great. So to protect the scope channel, when using the glue, you have some recommendation like, or use balloon to protect the scope, or just flush the channel with some oil or some olive oil or something?
Yeah, this is the, I generally don't use balloon, but this is the only case when we are using glue, I will put in a balloon. Second thing is, we have learned over the past, do not use lipoidol, because lipoidol in varices was used and it was slows the time, and the lipoidol will flow. What we have seen is it flows a track which you can trace all the way from submucosal fundal varices to the effluent into the renal shunt and then going on all of it. So if the one of the reason, if you think very big varix and you think the glue is going to go out of the varix, put in a coil. Somebody asked the question, when will you put in coil more often? If the varix is really very, very large, I will put in glue. And if especially if I make the mistake of mixing glue with lipoidol, then the glue will flow out of the varix. The flow is very fast. It will flow into the system. So better in these cases, put in a coil, one coil or two coil, and then start placing the glue. That is the best idea. So one of the question at that time, I thought there was another topic straight away on, but I would like to answer this question more in detail because I think we have another 1 or 2 minutes. When will you use exclusively EUS guidance for compared to endoscopic guidance? I would suggest you must know all modalities, and those people who are training their fellows for EUS as well as for endoscopy glue should ask them to do alternate, because one of those days there will be a possibility that you will not be able to stop bleed by endoscopy means, because endoscopic obliteration of fundal varix is not as easy. On the other hand, my take is EUS guided obliteration, once you have learned, it is very easy. The only thing is you have to make sure that you are going into fundal varix, not into extragastric varix.
Sure. So there is a question from Minish Mehta. Has anyone utilized portal pressure gradient measurement in patients that are status post tips to evaluate the patency?
No, no.
Okay. So I think we have so far answered all the questions that have come up, and it's now we are reaching our end of the session time. And I would like to thank Dr. Sharma. It's an honor for us to have you here at vascular therapies. It's really amazing to see how these are done. And again, Dr. Chin as well. And Dr. Chris, your concluding remarks before we end, and from the speakers as well.
Thank you, Adeel. I think we've had a really very nice webinar. It's nice to have the opportunity to come together at this time, you know, and hear these expert talks. My thanks to Pentex for convening this meeting. Of course, to our distinguished speakers, Dr. Malay Sharma, Dr. Chin Yung Ka, and to all of you for attending and you know, asking very pertinent questions. And please stay tuned. Dr. Adeel has some more webinars planned for you, and we hope to see you again, you know, online as soon as next month.
Dr. Sharma, thank you so much. Any last comments?
No, it has been a pleasure, and it has been a pleasure. The only last comment is, you have to be very, very passionate to deal with the vessels. You have to know them, know thy vessels, handle them, and then play with them.
Yeah. Especially when IR should be, or you're on backup, or surgeons on backup. Is it?
Yeah.
Dr. Chen, your last comments.
I have no anything, but I mean, thanks very much for the invitation. I think I learned a lot from the talks that Dr. Sharma given. Really, it's very enticing.
Well, I thank again the Pentex, Asia Pacific, Singapore, India, Pakistan for arranging all this, and all the IT support, and all our distinguished speakers. And the next third session, the theme for the third session will be, can EUS replace ERCP? So we'll come up with the speakers from different countries on that, and we're looking forward again. And thank you so much, everyone, all the attendees from all over the world. We had 600 plus registrants for that webinar, and I again thank you all very much. Stay safe, everyone, in this pandemic, and hope see you again. Thank you.
Okay. Good night. Good night. Bye bye.
Okay, thank you. Bye-bye.